Hello everybody and welcome to the Thursday edition of Video Clips. Okay, so I'm going to start with a kind of an unusual discussion today. I'll just start by saying I'm a libertarian capitalist. I believe in free enterprise and I actually prefer for the government to do as little regulating as possible. I'm the person who's always proposing the elimination of regulation and even the elimination of agencies that do the regulating. I've been successful in helping to get rid of a few and certainly to chip away at the power of several, particularly when it comes to licensure boards. So what I'm about to say might surprise you. For those of you who know me, I think it'll surprise you a whole lot. But I think the government needs to regulate advertising for healthcare services and drugs. Never thought the government needs to regulate would actually come out of my mouth, but I'm telling you we need to do this. I read a recent article in the New York Times that really articulated well what the problems are. So, in 2014, according to this Times article, the healthcare industry spent $14 billion in advertising. Drug advertising on television in particular has increased, along with advertising for hospitals. One episode of 60 Minutes featured ads for 4 very expensive drugs and 2 New York area hospitals, just one program. Of course, the drug companies think that the practice of advertising is a good idea. According to Holly Campbell, a spokesperson for pharma, advertising helps patients to make better decisions about their care. If you talk to healthcare professionals, they would tell you a whole different story, and experts routinely say that advertising increases the prices of the drugs and it results in patients asking for treatments that are often ineffective or inappropriate. And this might be why there are only 2 countries on the whole planet that allow advertising, the United States of America and New Zealand. All other countries prohibit direct-to-consumer advertising. Drug ads do tend to promote newer and more expensive treatments. This is why patients are walking into doctors' offices and asking for these treatments. There are no regulations requiring drug companies to state how much a drug costs, how effective it is, or if there are any less expensive options. Now, just a few examples. Xifaxan is currently advertised for irritable bowel. It costs $1,850 per month, and there really isn't any evidence showing that it's better instead of dietary changes or inexpensive over-the-counter drugs. Jublia, advertised for toenail fungus, costs thousands of dollars, has a cure rate under 20% if you take it for 48 weeks. And Movantik, a drug to relieve opioid-induced constipation, costs $350 a month, and there's no evidence that it works better than an over-the-counter laxative. And of course, dietary change would be the best. It would not only help with the constipation, but it would reduce the need for pain medication, since diet affects pain levels through inflammation and all kinds of other pathways. The FDA does have some rules for drugs. They can only advertise a drug company can only advertise a drug for conditions for which the agency's granted approval, and they have to list the major side effects. But there are so many ways to minimize the impact of those disclosures. The ads focus on patient testimonies, and have you ever noticed how the ads make it look like being sick is fun? All the diabetics are on the roller coaster, and you kind of want to join the party and sign me up for high blood pressure so I can have fun with these people. But anyway, at the end of the ad, the fastest talking man on the planet spouts out some of the major side effects, but that's a pretty minor part of the time. Drug companies also are very good at running ads in which they don't mention a specific drug, but rather refer you to a website for more information about a particular condition. And then when you go to the website, the drug is promoted. So the side effects don't really have to be listed in the ad that's on television. A website, so anyway, and then a recent study looked at this hospital advertising issue, which is just as bad as what the drug companies do. 409 ads placed by 102 cancer centers in 2012 were reviewed by researchers, and they reported that the benefits of treatment were described more often than risks, 27% versus 2%. They were only quantified 2% of the time, like this lowers your risk of dying by a certain percentage. The most prominent features of the ads were emotional appeals. 85% featured some type of emotional appeal from somebody portraying a patient. And then portraying hope for survival, 61%. Describing cancer treatment as a fight or a battle, 41%. And I always think back to Kelly Turner's book called Radical Remission about terminal cancer patients, where these patients, none of them, thought that cancer was a battle, that surviving cancer involved fighting and battling. In fact, they talked about making friends with their cancer and figuring out why they had cancer as one of the strategies for figuring out how to survive. So this is clearly false. Statements generating fear, 30% of the ads actually generated fear. Almost half the ads featured patient testimonials with few including any disclaimers at all, and none describing likely outcomes that patients will experience. The researchers concluded that cancer hospitals advertise their services using emotional appeals that generate hope and fear, almost no statements about risks, benefits, or costs. And so all this stuff that the healthcare profession says when they say that, oh, advertising helps patients make more and better decisions and lets them know what their options are. Well, that's assuming that the whole story is told, but in advertising, that's not what's happening, either when medical centers advertise or when drugs are advertised. And by the way, the FDA doesn't do anything to regulate hospital ads, which means people can say whatever they want in those ads. There's no regulation at all. Dr. Gilbert Welch offers, I think, some really sage advice about drugs and the marketing of medicine in his book, Less Medicine, More Health. The book includes a chapter addressing the myth that newer is always better when making decisions about treatment. And he describes several instances in which newer drugs or drug combinations or devices and surgical procedures resulted in significantly worse outcomes and even death for thousands of people. He advises patients to, quote, recognize advertising for what it is, advertising. And goes on to say, we've gotten really good at marketing medicine. Medical care and laundry detergent can be equally overhyped, but effective marketing does not mean effective care. New may represent a genuine medical breakthrough, but more often than not, it doesn't represent a major breakthrough. Now, you might wonder why I'm covering this topic, thinking to yourself, oh my gosh, I know the ads are just ads, and I'm not affected by this. And well, some of you may actually be unaffected and have that realization, but one of the reasons why drug companies and healthcare organizations are spending billions of dollars every year on these ads is because they work. There are people out there who are still drinking the Kool-Aid, going to their doctor's offices and asking for these specific drugs and calling cancer hospitals and other centers for tests and treatment and that sort of thing. So we've got to continue to put this message out that this is not ads on television, not the best way to gather data about what your treatment options are. All right, so let's transfer to another topic here. More studies are showing that physical therapy, exercise, diet change, and weight loss work just as well and sometimes better than surgery for knee pain. Now, why is this important? Well, millions of people have knee pain. 9 million people in the United States have osteoarthritis of the knee, and 35% of people older than 50 have confirmed meniscal tears. Now, the meniscus is a piece of cartilage that provides a cushion between the shin bone and the thigh bone, and it can tear when the knee is forcefully twisted or rotated, causing pain, swelling, and stiffness. And it doesn't even have to, when I say forcefully, it just doesn't have to be like a traumatic event. People who have poor posture, who don't have really good functional joint movement over a period of time, wear and tear can work away at the meniscus as well. Damage to the meniscus is really common in people who have osteoarthritis. Most people who have just a meniscal tear are asymptomatic, and studies have shown that people who have osteoarthritis and who also have a torn meniscus are not in more pain than people who don't have those tears. And 76% of asymptomatic patients have a medial or lateral meniscal tear. So the problem is that images and diagnostic testing don't really tell you who needs surgery and who doesn't. But over 465,000 people have surgery every year based on the discovery of meniscal tears. Well, the METEOR trial involved 351 patients who had osteoarthritis and at least one symptom of meniscal tear, which would include knee clicking or weakness that persisted for longer than a month after the patient had had some drug treatment, physical therapy, or tried to reduce activity as a means of resolving the issue. The patients were randomized to have physical therapy or surgery, followed by physical therapy. The physical therapy involved 1 to 2 sessions a week with a physical therapist, in addition to working at home on their own, and they were allowed to advance based on self-reported improvement. Patients in the surgery group had an average of 7 sessions. Those in the physical therapy group an average of 8, so not much difference there. The patients were evaluated at 6 months and then at 12 months. 30% of the non-surgery patients did decide to have surgery, but the surgery and non-surgery groups weren't much different at the end of 6 months or 12 months. In other words, having the surgery didn't really produce better outcomes than just having physical therapy. Other studies have shown similar results. There are quite a few good ones that have looked at sham surgery. Now you might wonder, how the heck can you have surgery as a, be part of the control group, had surgery, but it really wasn't surgery? Well, you give people anesthetic, local anesthetic, and you do, you cut and that sort of thing, but the patient really doesn't have any procedure done. Tearing of the meniscus and osteoarthritis affect large numbers of people. As I mentioned earlier, the cost of surgery is about $5,000 per knee. So what that translates to is in the United States, we're doing over $2 billion worth of knee surgeries every year just for meniscal tears. And probably most, if not all of those, are not helping at all. It's a lot of money to spend on a procedure that doesn't make much of a difference. And I think, again, my continuing mantra is let's just inform people. I mean, if somebody is given a piece of paper, it says this surgery is useless, but you have to sign here saying you know it's useless, but you still want to have it, I think it would really cool the enthusiasm for having knee surgery for meniscal tears. All right, so let's reserve surgery and toxic drug treatments for situations where it's really warranted after other better options have failed. And my gosh, if we did that, we'd reduce healthcare down from $3.2 trillion a year to probably $500 billion, and good half the doctors could find something else to do with themselves, and the patients would be a whole lot better off. All right, that's all for today. It's all for the week. As usual, pass this on to anybody who you think might enjoy watching it, and I'll be back to you next week with more news.